Spinal cord injury can affect and change bowel function. The clinical name for this condition is neurogenic bowel. Neurogenic bowel can have a significant impact on all aspects of a person's life, including health, self-esteem, and participation. When surveyed, individuals with spinal cord injury rank the loss of bowel control as one of their most life-limiting problems. Indeed, fear of incontinence is a common reason for not engaging in activities outside the home. Beyond the social limitations, bowel complications can be a serious health problem. Bowel complications are the 7th leading cause of death after spinal cord injury and the 4th most common reason for rehospitalization after injury. This segment will focus on changes in bowel function after spinal cord injury. It will guide viewers through the steps of a well-designed bowel program in order to minimize the complications associated with neurogenic bowel. The bowel is part of your digestive system, also known as your gastrointestinal or GI tract. In order to better understand the way spinal cord injury affects bowel function, it's important to discuss the way the digestive system normally works before a spinal cord injury. Everyone needs to eat, and your digestive system works to break down that food into nutrients your body can use and to eliminate what is left over as waste. When you take a bite of food, the saliva in your mouth starts the process by beginning to soften the food. As you chew, your teeth grind the food into a mush. When you swallow the mushy food, it travels down your esophagus and into your stomach. The acids in your stomach break down the mushy food into a more liquid-like mixture, and your stomach begins to slowly move that mixture into your lower digestive tract. Your lower digestive tract consists of the small intestine and the large intestine. The liquid food mixture from your stomach passes into your small intestine. The walls of the small intestine are lined with muscles that contract and relax in a wave-like action. This movement, called peristalsis, pushes the mixture along a path through the small intestine. Along the way, the small intestine breaks down the food mixture even more, and your vitamins, minerals, proteins, carbohydrates, and fats are absorbed into your bloodstream. These nutrients are what fuel your body. The food mixture that your body cannot use is waste that moves into your large intestine or colon. The colon absorbs moisture from the waste as the waste follows a question mark-shaped pathway up the ascending colon on the right side of the body, across the transverse colon, down the descending colon on the left side of the body, through the sigmoid colon, and into the rectum. In the rectum, waste is stored until it is ready to be passed out of the body through the anal canal. People use many descriptive words to describe this waste. Healthcare professionals call them bowel movements, BM, feces, or stool, among other terms. The urge to empty the stool normally intensifies as the rectum fills with stool. However, there are 2 muscular rings, called the internal anal sphincter and the external anal sphincter, that surround the anal canal and keep it closed tightly. As a result, the stool remains in the rectum until you're ready to go to the bathroom. When you're ready to go to the bathroom, your brain then signals the relaxation of the anal sphincter muscles, and muscle action from the abdomen, colon, and rectum pushes the stool out through the anus. This is a bowel movement. For most people, the digestive process is controlled from the brain that controls the voluntary action of having a bowel movement. But there are also a series of reflexes throughout the GI tract that are involved in moving the digesting food and stool along their path through the GI tract. The first is the gastrocolic reflex. When food or fluid enters into the stomach, it causes a stretch of the stomach walls. This stretch travels up nerves outside the spinal cord and triggers a reflex which causes peristalsis throughout the intestines. This reflex is the basis of eating or drinking, for instance, a cup of coffee 15 to 30 minutes before a bowel program, and will be discussed shortly. The next reflex is the colocolic reflex. This reflex results in constricting and relaxing of the bowel walls and essentially pushes stool along the colon. The next reflex is the rectocolic reflex. This reflex occurs in response to stretching and stimulation of the rectum or anal canal and causes waves of peristalsis along the colon. This reflex is the basis for the use of digital stimulation and suppositories when performing the bowel program in persons with spinal cord injury, and will be discussed shortly. The last reflex is the anorectal reflex. It involves a stretching of the anus, which causes contraction of the rectum. If you have a spinal cord injury, the nerve damage can interfere with messages between your body and your brain. While many of the reflexes may still work, you lose the ability to control a normal bowel movement. As previously mentioned, this condition is known as neurogenic bowel. There are two types of neurogenic bowel: reflexic bowel and areflexic bowel. The type of bowel will depend on the location and the extent of the spinal cord injury. If your spinal cord injury is at a level T12 and above, you likely have reflexic bowel. In reflexic bowel, you may not feel the urge or have the ability to push stool out to have a bowel movement. However, the spinal cord below the injury level still allows for coordination of appropriate bowel reflexes, so food and waste will move through the digestive tract. Between bowel movements, your anal sphincters will remain tightly closed. Your colon will respond to different types of stimulation, such as digital stimulation, or stimulant rectal medications, such as suppositories, with normal reflex actions that will allow for relaxation of the anal sphincters and reflex contractions of the colon and rectum to push the stool out. Even though the anal sphincters normally remain closed between bowel programs, a buildup of stool in the rectum can also cause a reflex bowel movement without warning. This is why it's important to have a regularly scheduled bowel program so that one can avoid bowel accidents. If you have a lumbar or sacral spinal cord injury, you most likely have an areflexic bowel. With an areflexic bowel, there is a loss of reflex coordination of the anal sphincters such that they now become loose or flaccid. This can lead to bowel accidents, a release of stool once it collects in the rectum. Also, since reflex coordination of the colon is lost, stimulation with digital stimulation or suppositories will not be effective. Stool absolutely must be removed regardless of your injury level. During your time in rehabilitation, you probably learned the importance of establishing a regularly scheduled bowel program. There are some basic goals of any bowel program. First, you want to be able to empty your bowel at a planned, regularly scheduled time. Second, you want to fully empty your bowel during your bowel program. Third, it should be completed within 1 hour from start to finish. Finally, you want to feel secure that you go through your day without any accidental, unplanned bowel movements between your scheduled bowel programs. The location of your spinal cord injury and whether you have a reflexic or areflexic bowel will determine how you manage your bowel program. If you have a reflexic bowel, you should plan on performing your bowel program daily or every other day. However, you may do it more or less often if it meets your needs. The first steps are to get you ready. If you eat a snack or drink something warm about 15 to 30 minutes prior to starting your bowel program, you can help promote the wave-like action and have more effective results. This takes advantage of the gastrocolic reflex, as previously mentioned. Get all of your supplies ready. You'll most likely need gloves, a water-based lubricant, underpads, wipes, and a stimulant medication such as a suppository or mini enema. You also need to gather any assistive devices you may need, such as a suppository inserter, finger extension, and digital stimulator. Wash your hands. It is recommended to be in one of two positions. If you can, it is best to sit on a toilet or commode chair to allow gravity to assist in moving stool out. To protect your skin from pressure ulcers, it's important that the toilet seat or commode chair be well padded, and if you're sitting for more than 30 minutes, be sure to perform weight shifts. If you cannot sit, lay in your bed with your body turned on the left side, with your right leg flexed at your hip and knee. Lying on your left side is preferred over lying on the right side because it eases the pushing out of stool. However, if you're unable to lie on your left side for some reason, then lying on your right side is fine. If you plan to do the bowel program in bed, be sure to place a sufficient number of underpads or chucks under you to catch the stool as it empties so you can avoid soiling the bed. Once you're ready, it's time for your bowel program. The first step is to manually remove stool from the rectum. With a gloved, lubricated finger, gently insert your finger into the rectum. Hook your finger around any reachable stool and remove it. If you use a suppository, use a lubricated finger to gently insert the suppository as high as you can on the wall of the rectum. If using the enemy's mini enema, wear gloves while lubricating the anus. To administer the mini enema, twist off and remove the tip. Place a few drops of the tube's liquid content on the shaft prior to insertion. Gently insert the tube into the rectum. Squeeze to empty the contents, keeping the tube squeezed until it is removed from the rectum. Suppositories and mini enemas usually begin to act within 5 to 15 minutes after their insertion. There may be some passing of gas or stool to let you know the stimulant is acting. When the stimulant begins to act, use digital stimulation to stimulate the wave-like motion needed to promote stool movement. This is done by gently inserting a gloved, well-lubricated finger into the rectum. Gently move your finger in a circular pattern for 20 to 30 seconds, keeping the finger in contact with the rectal wall. In people with a reflexic bowel, digital stimulation will cause contraction of the lower end of the colon and relaxation of the anal sphincter, promoting movement of stool out of the body. Repeat digital stimulation every 5 to 10 minutes until the bowel movement is complete. A hint that the bowel movement is complete is that upon performance of digital stimulation, the anal sphincter tightens rather than relaxes around the finger. Once the bowel movement is over, clean up the anal area and wash your hands thoroughly. If you have an areflexic bowel, you will probably need to do your bowel program once or twice per day. However, you may do it more or less often if it meets your needs. The steps are similar to those used by people with a reflex bowel program. 1. Get your supplies ready. You will usually need gloves, lubricant, and toilet paper. 2. Wash your hands. 3. Get positioned. It is recommended to sit on a toilet or commode chair. Remember, your anal sphincter is effectively flaccid, so stool can leak out, and your rectum and colon do not usually reflexively react to a stimulant like a suppository or digital stimulation. The stool, therefore, most often must be manually removed. This procedure is called manual disimpaction. This is done by inserting a gloved, lubricated finger into the rectum. Hook your finger around any reachable stool and remove it. Repeat manual disimpaction every 5 minutes. Between attempts to manually remove the stool, you might benefit from a few techniques to help promote stool movement. 1. Try firmly rubbing your abdomen in a clockwise motion called abdominal massage. 2. Try changing position by leaning forward and side to side. This also can help protect against skin breakdown. 3. Try inhaling air deeply and forcing the air out with abdominal pressure. And, if your doctor approves, bear down as if you are forcing stool out. The bowel movement is probably over when there is no stool after about 10 minutes, which is probably 2 manual removal efforts. Next is cleanup. Wipe with toilet paper or wipes and wash your hands. Your bowel program should normally take no more than 60 minutes, and you can consider your bowel program successful if you're able to completely empty the stool with no bowel accidents between bowel programs. A bowel program is part of total bowel care and deals with several aspects of your life, including bowel program frequency and the technique of scheduled assisted bowel movements. Diet and fluids, what, how much, and when you eat and drink. Activity level, how active you are, how many different positions, sitting, standing, lying, you are in during the day and for how long. Medications, what products you take for bowel care and for other reasons. These include oral medications you take to improve bowel function, stimulant medications you take to stimulate a bowel movement, and medications you take for other reasons that may affect bowel function. Although you may have problems with controlling your bowel movements shortly after your injury, most often you can retrain your body to have a bowel movement at the time that fits best into your schedule. Everything that you eat and drink impacts your bowel management. You need at least 15 grams of fiber each day to promote the health of your entire digestive system. Vegetables, fruits, and whole grain foods are generally recommended sources of fiber. Your water intake is also important to your bowel management. Water helps promote good digestive health. Fruits and vegetables are healthy sources of water as well as fiber. You may also promote digestive health through physical activity. This includes standing. If you're active, it helps keep the stool moving through your digestive system. There are a number of different types of medications used in managing neurogenic bowel. The following list is provided for educational purposes only. It is important that you talk with your doctor first before starting or changing any medication. Medications for managing neurogenic bowel fall into 4 general categories: stool softeners, bulk formers, peristaltic stimulants, and contact irritants. Stool softeners often contain some form of docusate, such as docusate sodium, cholase, and docusate calcium, surfac. Stool softeners act by attracting and mixing with fat molecules in the stool. This decreases water reabsorption in the colon and increases the water content of the stool, making it softer. These medications are commonly taken 1 to 3 times a day and are used to prevent or treat hard constipating stools. Bulking agents act to increase the bulk of stool in the bowels by absorbing water and expanding its volume. Bulking agents include psyllium, metamucil, fiberol, Natracil, calcium polycarbophil, Fibercon, and methylcellulose, Citracel. Often these medications are not prescribed in reflexic bowel, but are used in people with areflexic bowel. Peristaltic stimulants work by directly stimulating the nervous system of the bowel to cause peristalsis. The most common stimulant medications are those that contain senna. Brand names include Senokot, X-Lax Regular Strength, Fletcher's Castoria, Lax Pills, and Senogen. There are also a few combination medications that have senna and docusate together, such as paracolase and Senna-S. These medications are usually taken about 6 to 12 hours before your scheduled bowel movement. Contact irritants irritate the wall of the intestines and cause a reflexic movement of the bowel. They come in a variety of forms, including pills, suppositories, and large volume enema preparations. The most common contact irritant is Bisacodel, Dulcolax. When taken in the pill form, it takes anywhere from 6 to 12 hours to produce a bowel movement. The suppository can take 15 to 60 minutes, but the wait time can be shortened with the use of digital stimulation. Generic Bisacodel suppositories are combined with a vegetable oil base, so it may take a while for them to dissolve and for the active ingredient to come in contact with the colon wall. This can be overcome by using a Bisacodel suppository that is combined with a polyethylene glycol base that dissolves much quicker. For example, in the product called the Magic Bullet. Research shows that a polyethylene glycol bisacodyl suppository acts quicker than a vegetable oil bisacodyl suppository, significantly reducing bowel program time. Large volume enemas such as Fleet's enema are not typically used in routine bowel care in persons with SCI. Your healthcare provider can describe its use if needed. Enemies is a mini enema that contains docusate sodium in a polyethylene glycol base. Enemies functions as a hyperosmotic laxative by drawing water into the bowel from surrounding body tissues. The increased mass of stool promotes a bowel evacuation by stimulating nerve endings in the bowel lining and initiating peristalsis. Research shows that Enemies acts quicker than other agents, producing a bowel movement typically in 2 to 15 minutes. Enemies Plus contains the addition of a local anesthetic, assisting to numb the rectum and lower bowel. The formulation was developed for patients who experience autonomic dysreflexia or painful movements. Many other medications may be prescribed for people with spinal cord injury. Polyethylene glycol or Miralax can be used regularly or as needed to enhance bowel regulation. Other medications that may be used on an as-needed basis include milk of magnesia, magnesium citrate, lactulose, and sorbitol. All of these medications act by drawing water into the bowel from the surrounding body tissues. This increases the mass of the stool in the colon and promotes a bowel movement. Problem issues can occur even with the best bowel management. The two main problem issues are diarrhea and constipation. Many medications prescribed by your doctor can also cause problems. For example, antibiotics are often prescribed to treat urinary tract infection. The infection is caused by bacteria, and antibiotics kill bacteria. There are also bacteria in your digestive system that are healthy and help your body in many ways. Antibiotics can also kill these healthy bacteria, so it is common for people to become constipated or develop diarrhea when taking antibiotics. Many medications can impact your bowel program, including those you purchase over the counter. That's why it is always a good idea to talk with your doctor about the medications you're taking if you have any changes with your bowel program. It is important to recognize that one of the most common causes of loose stool or bowel accidents is constipation. While this may be counterintuitive that diarrhea may be due to constipation, what happens is that hard stool can cause a partial obstruction somewhere in the colon, and only liquid stool gets by. This is sometimes referred to as overflow diarrhea. If you have episodes of diarrhea or constipation, it's important to contact your healthcare provider to discuss treatment options. For people with spinal cord injuries with a level T6 and above, autonomic dysreflexia can also occur. Autonomic dysreflexia, or AD, occurs in response to a painful or strong stimulus below the level of the spinal cord injury and is a reaction of the autonomic or involuntary nervous system to overstimulation. AD is characterized by an elevation in blood pressure and is accompanied by a variety of symptoms, including headache, flushing of the skin, and sweating above the level of the injury, and goosebumps above or below the level of the injury. Common causes of autonomic dysreflexia include bowel impaction or distension, bladder distension, constrictive clothing, contact with hard or sharp objects, and sexual stimulation. AD can occur when the bowel contracts, especially if one is constipated or the stool is obstructed or impacted and won't come out. Inserting a finger into the anus as part of digital stimulation or suppository insertion can also lead to AD, so one should be aware of any symptoms of AD. AD will often improve or go away once the painful stimulus is removed or stopped. However, if AD does not go away, then this should be discussed with your physician as soon as possible. You should also talk to your doctor if you have other problems related to your bowel, including frequent accidents, little or no stool results from your bowel program, or the presence of blood during your bowel program. Some people with spinal cord injury may continue to have an ineffective bowel program. This can include inconsistent results, bowel programs taking greater than 1 hour, or frequent accidents. This can significantly impact someone's quality of life. If the bowel program is consistently ineffective, then one may need to consider alternative treatments. These can include bowel irrigation techniques, such as the pulsed irrigation evacuation system and the Peristeen anal irrigation system. There are also surgical options, such as colostomy and antegrade colonic enema surgery. These interventions are usually only performed if all the other methods fail. Therefore, you'll need to consult with your physician. One type of bowel irrigation system is pulsed irrigation evacuation, also known as PI. PI is often described as an automated enema in which small pulses of warm tap water are delivered into the rectum, serving to rehydrate feces and promote peristalsis. The PI system consists of a speculum, tubing, a disposable collection container, and an electrical unit that delivers positive and negative air pressure through the tubing. Another new system available in the United States is the Peristeen system. Peristeen is a transanal irrigation system that has been shown to be effective in emptying the lower bowels for persons with spinal cord injury related to neurogenic bowel, for chronic constipation, prolonged bowel programs, or fecal incontinence. The Peristeen anal irrigation system consists of a control unit, a water bag, and a rectal catheter. This system can be used on a routine basis and requires a physician prescription. A colostomy is a surgically created hole leading from the large intestine to a bag placed over the outside of the abdomen. The stool accumulates in the bag, and the bag is disposed of when it is full. For some people, a colostomy can be an option for health reliability and quality of life. Another surgical procedure that has been used most often in children is an antegrade colonic enema, or ACE procedure. This surgical procedure can allow for the emptying of the bowel by using fluid, similar to an enema, that is inserted into a small opening in the side of the abdomen rather than into the rectum. For this surgery, a small passageway is created between the skin of the abdomen and the colon, the large intestine, from another part of the bowel, or the appendix, and is brought to the surface of the skin via a small opening called a stoma. This is a less invasive procedure relative to a colostomy. During the first year after injury, you will likely be figuring out what does and does not work for your bowel program. Once you get into an effective routine, you discover that bowel management is an ongoing process. Your medications, what you eat, and what you drink all play a role in maintaining reliability in your bowel program. Even as you get older, you may need to adjust your routine to better manage changes in your bowel function. However, you can find the balance needed for bowel management. Then you can feel secure in your ability to live your life without worry of accidents. Good luck and good health.